Welcome to the Frank and Lizzie Show. We are here at SAWC once again for a great lineup. Now today, Liz and I have the great opportunity to introduce you to an amazing clinician, but we're going to take a deep dive into wound care innovation that's making a real difference in clinical practice.
So today's session, we're going to be talking about this fantastic, fascinating autologous wound care product called the 3C patch. And we have our very special guest. Dr. Green is a podiatric surgeon from Lake Charles, Louisiana. Oh, is that a Louisiana thing? I'm so sorry, I was not privy to that. So he specializes in the treatment of foot and ankle injuries. He's the president of the Louisiana Podiatric Medicine Association, professor at McNeese University, medical director at Christus Ochsner Wound Center. So that's at Imperial Point. Welcome, Dr. Green. Thanks so much for joining us.
Thanks for having me. I'm excited to be here.
So let's start with getting to kind of the technical side. Can you explain what autologous product is used in a typical wound setting?
Yeah, I mean, we've been using different products that come from the patient's body for years, and we know that it's a very good thing to have at bedside, very ease of use bedside, but also taking the patient's own body and using those everything that the patient has that's good and putting it into a wound seems like a novel approach. The way that 3C patch differs is that we're going to take all those different aspects that the patient has and harness it into a very robust patch, and that's where it's a little bit different.
Everything sounds great, but let's talk about the workflow, because a lot of times we ask, how can you implement this in a busy clinic?
Sure, and that's always the question, is that how is this is it going to delay my clinic flow? Is it going to delay my patient care? Am I going to have to see less patients? And you do have to work it in, but a lot of the time, the misconceptions is going to take a very, very long time, when really we're talking about a blood draw and a spin process. That's all usually within that patient window. The way I do it in my clinic is top of the hour, I'll have that blood draw and I'll have their blood spin down. By the time I'm ready to see them again, I've seen a few patients in between and I'm good to see them at that point. Usually 2 per hour is what I would recommend, but that's up to each individual clinician, but it does work well in there.
So do you have to have like any special training in order to use this? Like you mentioned, like you do the blood draw, but that's something like a medical assistant or your nurse or anybody could do, right?
Sure, the blood draw is pretty standard across. I mean, yeah, sometimes you need a little refresher course, if you haven't been doing them in a while. But as far as like the training, there's a little bit of a learning curve, but it's really a centrifuge that's very user-friendly. So you get the kit, where everything is kind of in there and everything is kind of easy to use. But as far as, a true training, it doesn't take very much.
Nice.
Even you can do that.
I think
what it sounds like. Dr. Green, we're all about clinical evidence nowadays.
Sure.
So let's talk about 3C patch and the effectiveness when it comes to wound care.
Yeah, so when you look at different, I teach residents and I try to teach them how to, dissect different literature and break it down. And one of the things that we always look at is it truly a healing rate over standard of care? And what is defined as standard of care? Is it a wet to dry dressing that, that they're trying to compare to? One of the big things I tell them is the run-in period, and with the 3C, you have a very robust, clinical trial that we could have included a ton of people in there, over 500 people, but they only had 269 in there. And so when you ask the residents, why only 269? Well, it's because they used a 4-week run-in period. So 4 weeks, if that patient didn't heal over 50% within 4 weeks, they were out. So now we're comparing really apples to apples. We're getting the patients that took a long time to heal or weren't gonna heal with standard of care, including offloading, including negative pressure, including all the different things that we do in the clinic. And now we're truly seeing the healing rate. And when you look at that, and 89% of those patients healed more than the opposite group, then you're starting to look at apples to apples, and you're starting to really compare things. So I think the clinical trial is there, the robust numbers are there, and that correlates to what I'm seeing in clinical practice.
Those are really robust rates. That's great. But since it's autologous, it's using the patient's own blood. So is there less risk of complications? Like I know, we have kind of this list of cultural things that we have to worry about with some patients.
Sure.
So tell us a little bit more about that.
Yeah, that's a great question. And I think that when you look at the lower risk factors. Of course, using the patient's own body is great, and you're able to really cut down on a lot of the risks that are associated with it. But another thing that we really see with that is I didn't realize the impact that it would have when you look at a patient and you get them involved in their caring. And what I mean by that is there's so many times you go into a wound care center and I'm going to put this amniotic tissue on you, I'm going to put this graft on you, I'm going to put whatever on you, and the patient just kind of says, okay, sounds good, I guess, and they don't really understand their treatment. This is something that really for the first time in my career as a wound clinician, that I'm involving the patient in their care to the point where they feel like they're truly in charge of it. So I say, hey, I'm going to take I've failed so far. I've not been able to get your wound healed. I'm going to take your own blood and I'm going to have you help me out. And then all of a sudden they're engaged and our no-show rates go down. Didn't really realize that. And these patients are coming into the clinic saying, I ate well, I didn't drink as much this week, I hope I give you a good patch. In Southwest Louisiana, that's a pretty big deal. So if they're going to give up their fried food for a little bit, that's great. So they really want to give us a good patch. And then when you show them that they're getting that healing, they're so much more engaged. And it's been such a game changer, within my practice to have that patient engaged like that.
Mm-hmm. And so I'm doing the clinical trials. Did you have any other findings? You just talked about healing rates, but what other findings did
Sure.
you find?
One of the things they documented was pain reduction, which, in some of those patients, is that really if they're insensate, does that really kind of give us a boost?
Sure.
Infection rates, cutting infection rates down. And when you look at infection rates, why would that be? Well, when you're looking at the different things that are within the 3C patch, and you're allowing that infection, that bacterial bioburden to go down, with the leukocytes that are within that's pretty impressive. Because we always talk about bacterial biofilm and bacterial bioburden and things like that. Does that play a role? I think it plays a role in cutting down that inflammation, whether that's the infective organism or not. So I think that's the striking part of it that I saw.
Mm-hmm. I do have a question for you.
Sure.
You showed us the kit, but there's 4 vials and they have different colors in it. Can you explain what we're seeing? Because that'd be helpful, because it looks like the last one is mine from Louisiana with the yellow.
So really, this is more of a demo of the stages of the process. So this is a little 18 ml vial that you'll get to put the blood draw in. And then we're looking at the process of the centrifugation and the coagulation and then compaction. So that's the last one, you're actually getting a patch in there. And yeah, just like what you're showing there, you'll get like a robust patch there where you're able to, it's a pliable thing. When we look at like PRP and different things that we've used over the years, I was always kind of confused as to how to use it. Do I just squirt it on there and put some gauze over the top? Do I inject it underneath? What are we doing? And with this, it allows me to put it on there and actually, make sure that, it stays in place and it's where I want it. And then when you look at it, and it's the side, you just put it down like that, but it's waffle to the wound.
Waffle to the wound.
I like that.
Okay.
See, that's a Louisiana thing. It's all about food.
That's it.
No chicken, all waffle. Yeah,
that's it.
Yeah. And it's got a little bit of thickness to it, so it feels like it's a matrix as well at the same time. It's not just like a solution or a flowable, where it's actually something that's quite tangible to be able to kind of cover the wound, as you will, like some things you kind of put on a wound and they disappear, and it feels like it's fairy dust sometimes, but this is a quite tangible thing for you guys to be able to apply. And then I'm assuming it's the same, you just have to secure it in place so that it stays within intimate contact with the wound bed.
You're exactly right. And most of the time securing it either with steri strips or bolstering it, it's not really something you would sew in, and it's real important to make the distinction between this and a graft. It's not a graft. It's not looking for coverage. It's looking for contact with the wound and giving the wound everything it needs to do to heal. So yeah, just making sure that it stays in place, in that area. I usually bolster it pretty well.
Mm-hmm. And that's great. And I'm going to tell you, Liz knows about this. I usually stay away from reimbursement, but let's talk about reimbursement because that's important. Is it straightforward? What should we watch out for? Can you enlighten us with that?
Yeah, it's pretty straightforward. I mean, it's about as straightforward as Medicare is straightforward.
I don't deal with that.
It is one of those things where you do have to document properly. You do have to make sure that that you dot all your I's and cross all your T's. And with national coverage determination, it's in there. So they have to accept that. And when you're looking at diabetic wounds, different chronic wounds, venous wounds, you have 20 weeks of treatment with this. So 20 weeks of treatment where you can apply this. So that's once a week if that's what you choose to do. But it is very straightforward when it comes to Medicare. With other providers, just like anything else, you send in the documentation and try to get approval. There's a very good help center and different approval process within the company that I've never had any issues as far as that goes. And if I did, it's more on their end trying to figure out what I didn't say. But I think with anything else, it's something that you have to document.
Yeah, and so in terms of like anything specific in terms of what you have to document, is there anything that you've learned that maybe you can share with our audience of the like really finite details of how to do that?
Yeah, I think, chronic wounds, making sure you document as a chronic wound, make sure why is to make it chronic. And if it's a wound that you're starting to talk about, diabetic wounds versus you mentioned pressure wounds and different stuff like that, just make sure your documentation's clear on that. But one of the best things, a picture, that says it all. So a lot of the time, if I send in a picture, those people aren't used to seeing clinical pics, and they usually approve it pretty quick on something like that. So I always like to send in pics because I do think that is something that insurance, they don't know as much about, and when they see that, they understand what the patient's going through, hopefully.
And I just have one more question because I think this is important to highlight in that workflow are you still like debriding the wound prior to the application and preparing it properly, correct?
Absolutely.
Okay.
You can still, you still definitely want to treat that wound just like you would anything else. Good debridement, absolutely with offloading.
Right.
Everything stays the same as far as that goes. We're just giving the wound everything it needs to heal from the patient's own body.
Great.
Well, great. And so this brings us towards the end of the show. Dr. Green went over what it is, the workflow, and the reimbursement as well. So it's a great product. You showed us the clinical evidence, and I follow this company, and I do see the results, and I had to learn all the research up front because we brought it into our clinic, and it's a phenomenal product.
Well, Dr. Green, thank you so much for sharing your expertise today. It was certainly insightful to learn more about this technology that I've kind of known about for years, but never had the opportunity to use.
Absolutely. It was great to be here, and it's great to meet you guys in person rather than just taking pictures with your cardboard cutouts.
And Liz, I'm famous because I have a case study in their website on a patient that we tried and we saved their leg. So we do want to thank you for being here, and thank you, the audience, for listening in.
Yeah, be sure to like, subscribe, and comment, and follow us for more.